Today we're going to be covering congenital heart defects. This is in your Hatfield book, pages 459 to 464. Here is an image of how blood flows through the heart. There are two videos that I posted. I suggest you pause this recording and go watch those two videos prior to listening to this. It'll make a lot more sense. You want to know the 5 adaptations of fetal circulation. So the fetal circulation is different from newborn circulation. There is immature capillary systems and a higher pulse rate. The higher pulse rate is because cardiac output can provide adequate oxygen to the body. Here are some interesting statistics about congenital heart defects. Continued interesting information about congenital heart defects. There are 4 different types of heart defects. So there's 4 different classes. The first is decreased pulmonary blood flow. This is when blood shunts right to left. Mixed blood flow is blood mixes. Increased pulmonary blood flow, blood shunts left to right in the ventricles or the aorta, which means the blood's going back to the lungs. And then there's obstructive defects, an obstruction of blood out of the heart. Those are the 4 different classes. Here is an image of the 4 different classifications. Hesse uses these 4 classifications, so that's why we're focusing on these 4 classifications to go along with your Hesse. Some normal congenital defect symptoms that you're seeing in most of these are going to be an increased pulse, increased respirations, a retarded growth, dyspnea or apnea, fatigue, and upper respiratory infections. Start talking about each of the different types of congenital heart defects. First one we're going to talk about is ventricular septal defect. VSD, an increased pulmonary blood flow, so blood goes back into the pulmonary system. With ventricular septal defect, your blood is being shunted from the left ventricle to the right ventricle because the left has a higher pressure. So it is moving from your left over here to back to the right, which means it's going back to the lungs. This is the most common defect, which is an abnormal opening between the left and the right ventricle, which means blood is forced from the left ventricle, which is oxygenated, back into the right ventricle. This usually causes a loud murmur. The right atrium and the right ventricle usually enlarge during this process because more blood is coming back to it. May cause congestive heart failure. The child can have frequent respiratory infections. Growth and development usually are not affected with this one. They could possibly be a little underweight, but then again, the growth aspect is not really affected. They can become weak and fatigued, short of breath. They could have poor feeding habits. They may be asymptomatic depending on the size of the defect. These may close on its own within the first year. They can be surgically repaired with good prognosis. As with most heart defects, you need to give antibiotics prophylactically before procedures to prevent the risk of endocarditis. Remember, this one has that loud, harsh murmur. There is no cyanotic or no cyanosis because unoxygenated blood doesn't go back into the left ventricle. However, if it continues a pressure increase on the right side, once that increased pressure on the right side, the blood could possibly be shunted back to the left unoxygenated side, which could cause that cyanosis. So remember, it's shunting from left to right because there's more pressure in the left ventricle. but as more blood is being pushed to that right ventricle, if that right ventricle starts building up the pressure, blood could possibly be shunted the opposite direction. Atrial septal defect, or called ASD, also has an increased pulmonary blood flow. With arterial septal defect, an abnormal opening between the left and right atrium. Oxygenated blood is forced from the left atrium to the right atrium. This may cause a murmur, congestive heart failure, or they may have no symptoms or no issues. The right atrium, right ventricle, and pulmonary artery will be enlarged. And what could be the problem here? If you remember your 5 adaptations, the foramen ovale may not be closed. Some signs and symptoms could be frequent respiratory infections, difficulty breathing, tire when feeding, shortness of breath, skipped heartbeats or palpitations. You may also hear a heart murmur. They can have swelling in the legs, feet, or stomach, and they could be at risk for a stroke. It is possible that an ASD might not be diagnosed until adulthood. One of the most common ways to diagnose ASD is by detecting a heart murmur. Usually surgery to repair with a good prognosis. They may attempt to insert an umbrella or a patch to plug the hole. Certain medications have been linked to a higher risk of an ASD, which is Zofran, Depakote, Paxil, and Zoloft. Patent ductus arteriosus, PDA, is increased pulmonary blood flow. Going back to our adaptations, where is the ductus arterius located? Give you a second. So remember, this is between the pulmonary artery and the aorta. So that is where our problem is. As you can tell in this picture, you can see that defect. So what's happening is the aorta has to increase the pressure. So because the aorta has increased pressure, blood flows back into the lungs. The heart has to work harder to get blood to the body, and the lungs become congested. So remember that ductus arteriosus is the fetal passageway in the heart that bypasses the lungs while in the womb. This opening should spontaneously close abruptly after birth. If it does not close, the aorta continues to push blood back into the pulmonary artery, overburdening the pulmonary circulation. Remember, this should close within hours after birth. Some signs and symptoms: a child grows dyspnea will start occurring. Bounding pulse, rapid pulse. A machinery-like murmur is heard. May cause congestive heart failure or pulmonary hypertension. They may be asymptomatic depending on the severity. Treatment can attempt to close with medications. Surgery is usually required with excellent prognosis. So in this, it makes the heart work harder to get blood to the body, and the lungs become congested. Another congenital heart defect is the coarctation of the aorta. This is an obstruction of blood flow from the ventricles. You can see the defect right there on the aorta. You can see how it is constricted. So it increases the left ventricle pressure, which increases the heart workload. So what's happening here is there's a narrowing of the aortic arch or descending aorta. They may not have symptoms until late childhood. A surgeon resects the aorta after removing the narrowed portion of the aorta. Some signs and symptoms could be a difference in blood pressure between the upper and the lower extremities. Also with the pulses, the upper is much stronger, which means they can cause severe lower body hypotension, shock, dizziness, or fainting. Surgery or angioplasty is usually the treatment option with good prognosis. So there is hypertension in the upper portion of the body and hypotension in the lower portion of the body. They can become dyspneic because everything is backing up into the lungs. They can develop tachycardia because the heart is trying to work harder to get oxygenated blood. And they become cyanotic because the blood is not getting to the body. Now let's move on to the tetralogy of Fallot. This is a decreased pulmonary blood flow. This is made up of 4 defects. So this is made up of 4 defects. You have pulmonary stenosis, which is a narrowing of the pulmonary valve in the main pulmonary artery. VSD, which is that ventricular septal defect, which is the hole between the ventricles. You have an overriding aorta, which means the aorta straddles the ventricular septum. And number 4 is you have the right ventricular hypertrophy, so the muscular wall of the right ventricle thickens. So here are the 4 different issues. You have number 1, that pulmonary stenosis. 2, you have this defect right here. 3, the aorta comes over you can see here where it's strictly over the defect if you follow this. So that right there is number 3. And then over here is the thickening of the right. So there are your 4 defects that goes with this congenital heart defect. The child has severe episodes during any physical activity, which is called TET episodes. This is a sudden restlessness, gasping respirations, and increased cyanosis. So this is their hypoxic episodes. They can also have squats to breathe more easily. So what if it's a baby and they can't squat? What should we do? We're going to place these in a knee-chest position to help them breathe. These episodes can last minutes to hours. The child shows signs and symptoms of dyspnea, feeding problems, growth retardation, frequent upper respiratory infections. Red blood cells enlarge to try to compensate for the decreased oxygenation. This can cause congestive heart failure, failure to thrive, and anemia. Here is an image to help you remember the acronym DROP, D-R-O-P, talks about each of the 4 conditions. Here is another image that you can utilize to help remember the 4 defects. Here is what a baby could possibly look like. You can see that they're cyanotic. You can see right here it's the TET spells that we were talking about. Treatment is we're going to give morphine because this decreases the cardiac workload. We're going to provide oxygen. Usually the patient has a good prognosis with treatments and surgeries. The last one is the transposition of the great arteries. This is a mixed blood flow. So here you can see that the aorta gets blood from the right ventricle and the pulmonaries get blood from the left ventricle, which is the opposite of a normal heart. So the aorta and the pulmonary artery are reversed. The child dies early if there are no shunts present. 'Cause remember, with this, the right ventricle sends blood to the aorta, which sends blood to the body, and the left ventricle sends blood to the lungs. A patient cannot live with this. This is considered a medical emergency. Surgery is necessary. So let's go over some nursing care for all congenital heart defects. We want to provide family coping. This means we need to allow time to grieve and express feelings. We're going to provide support and education about the disease. Make sure we're explaining all procedures. We're going to foster that attachment with the infant and child. We need to make sure that they understand they still need discipline and limit settings. Focus on what the child can do. Refer to support groups. use simple terms when we're talking to children, and of course prophylactic antibiotics for invasive and dental procedures. Nutrition is a little different for congenital heart defects because they don't have that oxygen and energy they need. So usually they can only tolerate small frequent meals, so we need to make sure we're providing high calories. May need tube feedings. If an older, they can use nutritionally dense foods that are high in calories. We want to make sure they feed in the upright position, and we want to feed them right after they wake up. So this means they have rested before, so they have that little bit more oxygen that they need to get that full feeding. These also may need to use preemie nipples if needed. So activity, we want to allow frequent rest periods and relaxed feedings. Let the child set their own activity limits, but we need to make sure they are not strenuous activity based on the doctor's order. Strenuous activity based on the doctor's order, if I could speak today.